Hello and welcome to Insight Ophthalmology. This is Dr. Amrit welcoming you to another lecture on exotropia. Today we are going to discuss about the symptoms and the scoring systems used in exotropia. So without any delay, let's get started. The evaluation of an exotropic patient begins with a proper history taking. It's very important to ask the patient regarding the onset of his symptoms, whether it was in infancy, early childhood, or was there a history of prematurity. Also, you have to ask about the frequency of the manifest deviation. That is, how often is the deviation present in terms of percentage of the waking hours of patient. Also, you have to ask when is the deviation more obvious? Is the deviation more when the patient is looking at a far distance, or is the deviation more when the patient is looking at a near distance? Also, we have to ask about the predisposing factors which might actually make a latent deviation a manifest deviation, like presence of fatigue, any health problem, recent vaccination, any viral illnesses, fever, presence of bright light, daydreaming, drowsiness, or visual inattention. Now, these are the factors which usually leads to manifest exotropia. Alright. So, why is the onset so important? At this point, let us talk about congenital exotropia. Congenital exotropia is also known as the infantile exotropia. It's a rare variety of exodeviation and it is said to be congenital whenever it is present less than 6 months of age. Okay, and 60% of the congenital or infantile exotropia are associated with other systemic conditions. These can be retinopathy of prematurity, craniofacial syndromes, ocular albinism, any midline defects, cerebral palsy, and genetic syndrome. Why is it important? It's important because the earlier is the onset of exotropia, the worse is the visual acuity prognosis. So, what I mean to say is, patients who have congenital or infantile exotropia usually will not do so well even after surgery. So the various symptoms that we can see in intermittent exotropia is the presence of headaches and eye strain, blurred vision and micropsia, diplophotophobia or monocular eye closure, panoramic vision, occasional diplopia, and also of course the symptom of or the complaint of eyes deviating outside. Okay, so now we'll discuss all of these one by one. First of all, let's try to understand the presence of strain, visual discomfort, and headaches. Now, why do you think a patient with intermittent exotropia should actually have these complaints? The thing is that patients with intermittent exotropia are basically manifesting their deviation only for some period of time during the daytime, right? And the rest of the time, they are essentially exophoric. Now, when they are in the state of exophoria, they're constantly using their accommodation, they're constantly using their fusional abilities in order to bring their eyes together straight, right? Now, because they're constantly trying to bring that deviated eyes inwards, they're putting a lot of effort, and this effort ultimately leads to fatigue and eye strain, and therefore also lots and lots of headaches, right? So that's the reason for eye strain, visual discomfort, and headaches. But the question is, why should they have blurred vision? Now, this also, the reason over here is again accommodation. Even when the patient is looking at far distance, the patient is using accommodation in the case of exotropia, right? Now, this accommodation will basically help them to recruit their accommodative convergence and will help them to bring their eyes closer and therefore will help them to be orthophoric, right? However, this happens at the expense of visual acuity. Although their eyes will become straight, but their vision will become blurred because of excessive accommodation. Over here, mind you, the use of accommodation by the patient is not to get a clearer image, but instead, the use of accommodation by the patient over here is so that he can use his accommodative convergence and bring the eyes which were deviated outward inside, right? So that's the purpose over here. Also, what happens here is that they will suffer from something known as micropsia. So often these patients are going to have complaints somewhat like this. So they might actually tell you that whenever they look at the distance objects, things will go in and out of focus, and also the things will appear much more smaller. It's as if they are looking through the wrong end of binoculars. So why do these things appear smaller than normal in cases of intermittent exotropia? Now again, this happens because of excessive accommodation. What happens is that whenever excessive accommodation is used to maintain the alignment of the eyes, the brain is interpreting the resulting image as reduced in size. Okay, so it's all happening because of excessive accommodation at distance, right? So this type of smaller images or perception of images as smaller ones than normal is known as micropsia, right? So this is particularly noticeable in cases where individuals habitually use accommodation to control their micropsia, right? So control their exotropia, right? So in summary, micropsia is also stemming from accommodative effort which is required to manage the eye's position, and also the blurred vision is also manifesting because of that accommodation. The thing is, as an examiner, how do you know that the patient is accommodating at distance or not? Very simple. You can actually compare their visual acuity tested both binocularly and also monocularly. And you will find that when you are testing visual acuity with both eyes open, that is known as binocular visual acuity. And when you're testing visual acuity with one eye, which that is how we normally test, so that is called monocular visual acuity. And it is seen that binocular visual acuity in these patients is poorer than the monocular visual acuity. And why does that happen? It happens because we know that accommodation is a binocular process. For you to accommodate, both the eyes should be working together, right? And therefore, when we are testing binocular visual acuity, the patient is accommodating at distance, and therefore at that time the visual acuity is lower, okay, compared to when you're testing monocular visual acuity when there is no accommodation present. Okay, so by carrying out this test, you can actually find out whether the patient is accommodating at distance or not. All right, so we discussed about the headaches and eye strain, we discussed about blurred vision, and now also we discussed about micropsia. Now let's talk about diplophotophobia or monocular eye closure. Now, often in intermittent exotropia, what is commonly seen is that the patients will close their one eye in response to bright light, right? Now, this phenomena is known as monocular eye closure or diplophotophobia. Now, the term is self explanatory here that the bright light is inducing diplopia. Now, there are a lot of reasons and theories behind as to why it happens. Now, let's try to understand a few of these theories behind diplophotophobia or monocular eye closure. Now, the first theory is that of retinal dazzle disrupting the fusion. Okay, so what exactly happens over here is that it is believed that high illumination can actually overstimulate the retina, leading to a dazzle effect on the retina. And studies by Von Nuden and Wirtschafter has actually showed that this dazzling effect adversely impacts the fusional convergence. Okay, so in simple terms, in bright light, the retina gets overwhelmed, making the fusion really challenging. And what happens when fusion gets challenged? When the fusion is not proper, the eyes are going to be deviating outwards, and then that is going to lead to diplopia or confusion in the patient. And in order to avoid that diplopia, the patient is going to close one eye, right? So retinal dazzle leading to disruption of fusion is one theory behind monocular eye closure or diplophotophobia. What about another theory? Another theory is that of pupillary constriction and reduced accommodation. Okay, I would really like to apologize for the background noise over here. Some construction work is going on around the corner. So, okay, so let's come back to the theory. So, here we'll talk about the pupillary constriction and reduced accommodation. Now, in bright light, what happens is that the pupil is going to undergo constriction, right? Now, as the pupil undergoes constriction, this will increase the depth of field and it reduces the need for accommodative effort to some extent, right? Now, if the need for accommodative effort goes down, there will also be reduction in accommodative convergence. And this is and it is actually the accommodative convergence which helps to bring the eyes closer or inside. Now, if accommodative convergence fails, obviously what's going to happen? The eyes are going to diverge, exotropia is going to become manifest, and the patient is going to suffer with diplopia, and therefore to avoid that, he's going to again try to close one eye. Right? So that was the theory of pupillary constriction and monocular eye closure. Another theory is that usually in bright outdoor settings, we have very few near cues, and therefore it is actually a very less stimulus for convergence, making it more likely for exotropia to appear. So what I mean to say is that when you're looking at far, you're not really converging your eyes because your near cues are less, you're looking at a distance, there's more divergence, and therefore exotropia appears more. What about binocular photophobia threshold? Now, this theory was given by von Uden again in 1970, and he said that as such, exotropic patients have a much lower binocular photophobia threshold. So basically, Von Uden and Wiggins in this theory said that it's not really the diplopia or confusion which causes monocular eye closure, but as such, it is the anticipation of diplopia, and as such, it is the lower binocular photophobia threshold in these patients that the patient is going to close their eyes even before confusion actually manifests or double vision manifests. Another very simple theory given by Eustace and Greffy was that exophoria becomes decompensated in these patients in high illumination settings, and therefore, as the exophoria is getting decompensated, to prevent all that discomfort, patient will close one eye. Right? So many theories, but I hope you understood exactly what is meant by diplophotophobia or monocular eye closure. Right? Now, let us talk about the panoramic vision and what exactly is meant by that. So, you might all have heard about panorama and the panoramic photographs that we take on our phones these days. Now, this confusing situation can also arise in case of exotropia. So, in very simple words, panoramic vision in exotropia basically happens because of the outward deviation of one eye or both the eyes. Now, this outward deviation of the eye is going to actually give the patient an advantage of widened field of view, as you can see over here. Now, this happens because each eye actually has its own field of vision, right? The eyes are misaligned and they're directed outwards. Now, this causes each eye to capture visual information from a broader angle and thereby enhancing the total peripheral field of vision. Normally, in binocular single vision, what happens is both eyes are going to converge on one single point, and then there's going to be sensory and motor fusion, and the two eyes are going to work as a single eye, more like a cyclopean eye. But in exotropia, the eyes really don't converge onto a single point. Instead, each eye views separate part of the visual field, increasing the overall horizontal coverage what the patient is going to see. Right? So this is known as panoramic vision, and this is actually advantageous to some patients. Now, why this happens? This happens because of a lateral placement of the eyes. This actually happens in some animals. For example, over here you can see the eyes are basically placed more laterally, and since the eyes are placed laterally, they are going to have a greater field of view. However, humans have this forward placement of the eye, and therefore we have lesser field of view. Something similar happens in exotropia because the eyes move outward, the field of view increases, and this is known as panoramic field of view or panoramic vision. All right. The last symptom is that of occasional diplopia. So, patients with exotropia can also complain about occasional double vision. Now, this happens in the early stages of the intermittent exotropia. Over time, as the patient develops suppression, abnormal retinal correspondence, then the patient will be able to prevent this double vision. However, adults don't have this luxury. Okay, if someone has a late onset exotropia, like what happens exactly in third nerve palsy, for example, these patients are going to actually have constant double vision. Why? Because adults, they do not have this neural plasticity to develop mechanisms like suppression and abnormal retinal correspondence. So that is something that you should actually remember, right? So diplopia or double vision. And of course, patients, and mostly it is the parents who complain about exodeviation, who might say that the child is actually having outward deviation, right? So, this might actually be the most common presenting complaints by the patient, and it is usually noticed for distance in the beginning. Now, over years, as the disease progresses, the deviation becomes more frequent and of prolonged duration as well. Ultimately, the deviation is going to start appearing for near also, and then it might become a constant deviation. Now, what are the factors that affect the progression of different stages of exotropia? Now, we have discussed this in our first video on exotropia, where we discussed what exactly causes exotropia, right? So, as the convergence ability of the patient decreases with age, exotropia progresses. Also, there's a gradual loss of accommodation power, and as the sensory adaptations like suppression and abnormal retinal correspondence develops, the patient will not have diplopia anymore, and therefore the patient is not going to put now more effort trying to fuse those images, and therefore exodeviation is going to become more and more prominent as the disease progresses. Okay, now there are a lot of scoring systems for exotropia control. We have a PDIC score, we have Newcastle scoring system, we have Mohney and Holmes score. Now, in this video, we shall be talking about these two scores, right? So, first, let us talk about we'll talk about the Mohney and Holmes score, all right? So, examination of an exotropic patient, the whole purpose over here is to assess the level of control over exotropia and to detect the abnormalities in the visual and binocular function. So, first let us talk about the Mohney and Holmes score. Now, this score evaluates the control of intermittent exotropia based on the observation of eye alignment during a 30-second period. Okay, now it can range from 5 to 0. Initially, the clinician will observe the patient for 30 seconds without any intervention, right? Now, if the exotropia is noted, the patient is going to be scored accordingly from 5, 4, and 3. So, what I mean to say is the patient is going to be observed for 30 seconds, and if the exotropia is constantly present during that 30-second period, then the score of 5 is given. If the exotropia is present in more than 50% of the time during that 30-second period, then the score of 4 is given. If the exotropia is present for less than 50% of the time period of 30 seconds, then a score of 3 is present. 3 is given. Okay. Next is, if there is no exotropia in that 30-second interval, then the clinician is going to intervene by dissociating the eye. It could be simply by using a cover uncover test or by covering one eye, right? Now, after this, the time that the eye takes to regain its alignment is going to be noted, and based on that, the patient is going to be scored from 0, 1, and 2. If the patient recovers immediately, less than 1 second recovery, okay, after a 10-second of dissociation, the score of 0 is given, and it means that the patient has pure exophoria, okay, and not any exotropia. However, if the patient recovery basically takes 1 to 5 seconds, a score of 1 is given, and the recovery basically takes more than 5 seconds, and the score of 2 is given. Okay, so as you can see, the severity of scale is from 0 to 5. The fifth one is the most severe. Now let's talk about the Newcastle score, and this is the most popular score and commonly asked score. The Newcastle score, and even we have an updated Newcastle score, it incorporates the data from both the clinic visit and also from symptoms which are experienced at home. And here the patient is going to be scored from 0 to 9, and 9 is basically the worst control. So scores over here are going to be taken from home, the control at distance, and also the control at near distance, right? And all those things are going to be added to calculate the final score. So first, let us talk about the home control. Here, the evaluation of the control is going to be done by the parent himself, right? So you ask the parents to observe their child at various times during the day, okay, and specifically when the child is looking at distance or when the child is focusing at a near object, when the child is reading or maybe looking at a toy, and other times when the child is actually looking at a distance object, right? So If the parent actually says that whenever they're observing the child fixating at a distance, they see the presence of exotropia for less than 50% of the time, then the score of 1 is given. If the parent says that the child was having exotropia more than 50% of the time when fixating at distance, then the score of 2 is given. And when the parent says that the child was having exotropia for less than 50% of the time when he was fixating at distance and also seen at near, then a score of 3 is basically given, right? So this is how the home control is assessed with the help of the parent. Next, we will assess the clinical control. Here, the exotropia is observed at near and also it is observed for distance, right? Now, if the patient comes to you in the clinic and the exodeviation manifests itself spontaneously, or what I mean to say is if exotropia is observed just like that, then a score of 3 is given. But if the exotropia is not present at that time, then the doctor is going to use dissociation. And if the exotropia remains manifest after dissociation or prolonged fixation as well, then it is a score of 2 is given. It means that the patient is not regaining his alignment, right? However, if the patient is able to realign his eyes after a blink or after refixation, then a score of 1 is given. Okay, and if the patient is able to realign his eyes after dissociation almost immediately, then a score of 0 is given, right? It's quite intuitive if you look at it. If the patient already has deviation when he comes to you, a score of 3 is given. Then you dissociate the eyes and then you look for the realignment of the eyes. If the patient is able to realign it immediately, a score of 0 is given. If it takes the patient to blink his eyes or fixate at something, a score of 1 is given. And if the patient is not able to realign his eyes after your dissociation, then a score of 2 is given. Okay, so in the end, what you do is you basically add up all of these scores and then you give a total score. Now, for example, if the parent actually tells you that he was able to observe the presence of outward deviation for more than 50% of the time fixating at distance, for home control, you will give a score of 2, right? And then on your clinical examination, you found out that the patient was not having exodeviation, but after dissociation, he got exodeviation, and then he could realign his eyes with the aid of blink or refixation, both at near and at distance. Then you will give him a score of 1 1 each, and now you will add all these three and get a score of 4 on 9, right? So that is your Newcastle score, right? So your total score will be 4 by 9. Okay, so that was about the symptoms and the control of exotropia and the various scoring system. I hope you found it useful. If you did, kindly share it with your friends as well. And in our next video on exotropia, we shall actually be dwelling into the measurement of exotropia and what are some important tips and tricks that you have to keep in your mind while basically examining a patient with exodeviation. And in the final video, we'll talk about the treatment of exodeviation. So stay tuned. Thank you and have a nice day.